Good morning. My name is Mohsen Banazadeh. I'm one of the fellows at Mount Sinai. Presenting a complete endovascular repair of acute type B aortic dissection with a concomitant large juxtarenal abdominal aortic aneurysm. Patient, 67-year-old obese male from came to us via air from the Dominican Republic. He presented there with abdominal pain and back pain. And the CT over there revealed a type B aortic dissection and a large juxtarenal aneurysm. Past medical history for hypertension and a known AAA. He was a smoker, obese, and on PPIs and beta blocker. At presentation in emergency, his blood pressure was 180 to 200s. Other than that, he was in no acute distress. Belly was soft. Extremities were warm. Labs were within normal limit, but the creatinine, which was 2, here are axial images of the dissection, starting from the left subclavian to large fenestration, extends down into thoracic, another fenestration in mid-thoracic. True lumen is pretty small. The abdominal part, the SMA comes off true lumen. Celiac, SMA, true lumen, and right at the level of renal, you have dynamic obstruction of the aorta, and then below that, you have a large 8-centimeter aneurysm. Iliac and axis looked fine, but he was an obese gentleman. These are the sagittal views. You can appreciate the extent of the dissection and the fenestration. You can see one fenestration right there. There were multiple, and obviously it goes all the way up to the left subclavian artery, through lumen, SMA celiac, and then the juxtarenal aneurysm. So at this point, so as far as we started the medical management, obviously made the patient to the ICU, brought the blood pressure lower with beta blockade and calcium channel blocker. And then the question was surgical management, what are the options, what are the indications? Do you want me to go through this or any? All right, so we decided to treat the dissection first because the patient was symptomatic with the type B dissection. We decided to do that in a stage fashion. Here is the angiogram. All the mesenteric vessel come off the true lumen dissection. We perform an IVUS. There was no type A component. This innominate coming off, and then left subclavian right there. Then the other thing I wanted to point out is the large fenestration up there, another fenestration here, and then also the dynamic obstruction of right by the renal artery. So we perform.
Doctor, what would you do in a case like this? You got a guy came in with an acute type B dissection. By the way, he's got an 8-centimeter aneurysm, juxtarenal aneurysm, pressures of 180.
I think he saw me playing on my phone. That's why he picked up.
I know you see these patients. So.
It's a difficult situation, right? Because you're type B, if you try to do some type of endo repair and you can't get a seal proximally, then you accomplish nothing. And with continued perfusions, I saw pretty briefly, but I didn't see the whole thing. The other option, obviously, is open repair, but with open repair, the tissue is very friable. I think based upon my caveat again, as I was trying to fix something on my phone, is I think with this patient, I probably, if they're a candidate, I probably would favor open repair. Obviously, Teflon reinforced or felt reinforced anastomoses. Understanding that, and again, I didn't see where the dissection ended, whether you could get a proximal seal or not. But I think your main problem here is your aneurysm. That's an aneurysm with an acute dissection is a portent of very, very poor prognosis.
So what would you do?
I couldn't see the renal arteries very well. We have access to fenestrated technologies, for example. So we have to study the CT scan, and if we have the chance, we would stand the thoracic aorta down to the diaphragm and then put the fenestrated graft.
Mohsen, go back up to the angiogram. I think the real concern, as Moshe was pointing small right around the visceral and renal arteries. Does that change your thought as you're looking at a fenestrated graft if you've got 16 or less millimeter lumen in that area with a large false lumen?
We don't really care about that. We have experience in aneurysm in chronic patients, and in this case, we have the possibility to wait, put a stent graft first, wait, and usually we have some place for the fenestrated graft. In this case, we have an acute, complicated case. So I do really think that we have the possibility to have room enough to place a stent graft there, a fenestrated one. Obviously not branched.
Yeah, unless you have an internal branch, I guess. I would think maybe an internal, if you can actually have an internal branch for it, so it's not on the outside of the graft. But that was a concern here that we had, was just that you had such a small area to work with. But again, to your point, we thought the first thing that should be done is manage the lead point and then see how much opens up after that. So now, most of that kind of shows the proximity. It's really, the dissection really goes right up to the left subclavian.
Yes, right. That's left subclavian right there. And then the dissection goes up. So we decided to perform staged endovascular repair first. Then we decided to preserve the subclavian, perform a bypass, and then embolize it and perform a T-VAR, percutaneous access. You see the graft, subclavian graft is open, amplacid plug, and then T-VAR coming down. Then we placed the patient back to the ICU. He did fine from the first initial procedure, hydrated patient. His creatinine was 2, remained 1.82 range. A week after, we came back and then did a 4-vessel snorkel, double sandwich technique. Got access to right axillary artery because the left we had the bypass on the left, and groin, percutaneous access, extended down, put another Cook device all the way up to the celiac, and then cannulated the SMA and celiac, put the stent graft in there, and then extended down with a TX2 cuff.
You use your right subclavian?
We used the right subclavian to do this, to cannulate it. And then good perfusion of celiac and SMA, and then cannulated the renals, both renals, place a abdominal cuff, and sandwich those two. And then perform the zenith bifurcated and complete the repair. At the end of the procedure, there was perhaps a hint of endo leak. We decided to take the patient off the table and then follow that up. Patient did fine post-procedure. Went home after 4 days. Follow-up CAT scan after 1 week. Good remodeling of actually the proximal aorta, descending aorta. Remember, the true lumen was really compressed here. And then coming down, again, good remodeling after like almost a week. SMA and celiac stent grafts open, and then renals were open. There was a little bit of endo leak here. We decided to observe that. The patient came back with increased creatinine due to his body habitus. Duplex was limited, so we performed, after 1 month, we performed another diagnostic angiogram, which I'm going to show it to you, which basically showed good perfusion of all the stent graft with no evidence of endo leak, right here. So everything was open. We performed multiple oblique views, and there was no evidence of any gutter leak or endo leak.
Excellent. Congratulations. It was a really tough case.